So with this note, I think we should move on to the sessions. The first thematic session today is rodenticide poisoning. I welcome Dr. C. Eapen Sir, Head of Hepatology Department, CMC Vellore, to talk to us about what is unique about Tamil Nadu Government protocols, the non-transplant treatment. Welcome you, sir.
Thank you, Lydia, and good morning, friends. I consider it a privilege to being able to join this important meeting today and to address you on this particular topic assigned to me. Before starting, let me acknowledge my thanks to Dr. Arun, Mission Director at TAI NHM, and Dr. Vineet, Commissioner of TAI NHM, for making this workshop happen, and also especially Dr. Narayanasamy, Vice Chancellor of Tamil Nadu Dr. MGR University, for his constant engagement and support on this important topic, and Lydia and a variety of other important experts who are here in the field. Now, literally, all of us are engaged in looking after patients who consume rodenticide poison, which is a huge problem in this part of the world. And the question is, how many lives saved does it make an important topic? When you think it through, the answer is one. If one life is saved, it's a huge thing. So if you save 50 lives, it's phenomenal. 100 lives. So all of us are engaged, all of you are engaged in that, primarily in the government sector. I appreciate this. At the same time, I'm underlining the importance of this topic. Now, it is true that the survival of patients who consume rodenticide and develop liver failure from a very severe death rate is improving a lot in Tamil Nadu. That's a sense that we're getting on the ground. Is that true, or is it just one sense? Okay, so some data will now come out today, and you can look at that and yourself think for yourself, where have we reached? Second, this is not a problem only in Tamil Nadu. This is a problem also in other states in South India, as well as we know it is there in Maharashtra as well. Some of the states have started implementing PLEX. Many have not. None have done at the scale of what Tamil Nadu does. So I hope and wish that this could be extended in other states where a similar problem exists, and all of you who are leaders in your own field, in your own sections, should take the initiative in spreading the message. Lastly, the lack of access to urgent liver transplantation for the number of patients that we see forced us to look for non-transplant options. So by doing that, that has informed the field in the whole world. In the whole world, this example is informing the field of how treatments can happen without liver transplantation. And then maybe even in the Western world, they may start following this model once the logic comes through. With that introduction, maybe I'll start my talk. So I'll cover in the next 7 minutes what is unique about the Tamil Nadu protocol. Now, first I would like to just say as to, in this journey, how did we get to where we are now, and then what is unique about the protocol. So next slide, please. Okay, in an important study done by the Tamil Nadu chapter of the Indian Society of Gastroenterology, the TNISG, in the year 2019, over a 6-month time period of 244 patients who developed acute liver failure in 6 districts of Tamil Nadu. There are 38 districts now. In 6 districts of Tamil Nadu, only one patient, that is 0.4%, could undergo liver transplantation. So it is true that access to urgent liver transplantation is a big problem in Tamil Nadu. Urgent means I need a transplant in the next 2 days. It's different saying I can have a transplant over the next 2 months. So now the person with acute liver failure does not live beyond one week. So it all has to happen within, so that is the challenge. And that is a problem that we face. Next slide, please. Now it's estimated that 50 to 75 urgent liver transplants for acute liver failure happen in India per year. So this is, when you look at it, it's like this aeroplane landing in Mumbai airport, and Asia's largest slum is on the side wall of the airport. The slum dwellers every 2 minutes looking at the aeroplane going in the sky. But in the whole life, he may not get on the plane. So it is just like that, really. The acute liver failure and access to urgent liver transplantation is like this. Access is the problem. Now, this randomized control trial from 3 European countries established that there is a 10% increase in survival of patients who did not undergo liver transplantation after having high volume plasma exchange, where the predominant cause of acute liver failure was paracetamol overdose. So this led to the Tamil Nadu ISG, the TNISG, to bring out guidelines to say what are the indications and contraindications for plasma exchange to treat rodenticide-induced liver damage. And these were brought out as guidelines in 2022. Next slide, please. Within about 3 months, the Tamil Nadu government, the Thai NHM, mostly based on these guidelines, brought out the Tamil Nadu government guidelines, which the handbooks are available here. I can see that, the updated handbook. And so that is something amazing. Tamil Nadu only has got that set up for so much of a public health impact and to rapidly implement that. Next slide. So in 2009, one of the articles on treatment of acute liver failure gave 2 treatments. One was standard medical care, and second is liver transplantation, urgent transplant. As I said, urgent transplantation within the next 2 days. But in the last year, a Lancet review article says now there are 3 treatments: standard medical treatment, urgent liver transplantation, plasma exchange. Next slide. So with that background, what is unique about the Tamil Nadu government protocol? Next slide, please. So this is a picture of George Washington, the first president of America. Now in the year 1799, at the age of 67, after retiring from his president's post, he developed one fever and sore throat and some difficulty in swallowing. 200 years later, this article in the New England Journal thinks that he died of acute bacterial epiglottitis. This is an era when there was not yet a word called infection, inflammation. These are all not yet described. They say germs. These are like that. There's no antibiotic. So one of the doctors felt that we should let out bloodletting. So in a period of 18 hours, 3 times he had bloodletting done to treat this problem, and he died. 40% of his blood was removed. And by the next day, the newspapers all said, you did wrong, you killed him. That remains a perception even now, and maybe it is true. So the treatment that we say is one form of blood purification. Here they did not do that. They only let out the blood. Is a dangerous treatment in a seriously sick patient. So where did the doctors go wrong in blood cleansing treatment? In the last 200 years after Washington died, PLEX is now standard of care for more than 600 diseases. I'll give an example. Neurological diseases like Guillain-Barré syndrome, TTP, HUS, in different organs. But for liver failure, it is fairly new. So we have to be sure about selecting the patients. I must say, after being in this field now for the last 10 years or so, particularly in rodenticide poisoning, many things I am unsure about, and we are learning all the time. So it is not correct to say we know it all, and we should always keep up to date on what are the newest ideas in this field. Next slide, please. So what is new? The European Association Study of the Liver, the European guideline says that for acute liver damage after paracetamol overdose, the treatment of plasma exchange comes in acute liver failure, especially if there is no transplant option. The 2 differences in the Tamil Nadu protocol I've given in blue at the bottom is one, for us, PLEX, we have decided that we should do it earlier in the illness. Why not? Why should we wait till the person is unconscious? So we are doing in the face of acute liver injury. That is the first difference, the uniqueness of our protocol. This is the only such protocol in the whole world right now, compared to the European guidelines. 2, we are doing it as the first option before liver transplantation. In Europe, they say if there is no transplant option, majority will get transplant, then they go to plasma exchange. We are reversing that order. Next slide, please. We also thought, what else can we do? So one of these guidelines, which now clearly we are stating, in a person who is not in encephalopathy and has consumed poison, is in liver damage, liver hepatitis, or coagulation abnormality, do not sedate. This is similar to the guidelines for snake bite and neurotoxicity. A similar guideline is given by the NHM across India. Next slide, please. Now, just to give a sense of numbers, in this paper, in over a 21-year time period, in 22 countries in Europe, how many patients underwent urgent liver transplantation for paracetamol overdose? I am calculating from that article, it appears 26 patients per year. This with all the resources available in Europe, they can do it for 26 patients per year in 22 countries in Europe. So it's only a small number who can actually access urgent liver transplantation even in the Western world. Next slide, please. Now in UK is a country which is smaller than Tamil Nadu, both in geographical size and much smaller number of population. For allocating livers for liver transplantation, the country is divided into 7 regions, and one center in the region is where the transplant is done. So if there is a cadaveric donation within any of the catchment area of the region, they will share that liver within the region. But if somebody needs an urgent liver transplantation, they will allocate across the UK, the next liver will come to your center. That's how they work. Next slide, please. In Tamil Nadu, what we've done instead, and that is the protocol which we are being followed now, the aim is within each district to triage the patient who needs plasma exchange. So that as you can compare, there is some similarity with the UK system, but some things are better for our scenario, and maybe that's how it works. As Dr. Vineet mentioned, as of now, I believe 18 districts have got this facility. It's not only the machine. In fact, the machine is only one component. It's more about a team and a protocol, how to make it happen. Next slide, please. Now, this appears to be scalable, and as this publication in Lancet showed that in the years 2022 to 23, 1,237 patients under the Thai NHM scheme underwent plasma exchange. But I think that's not accurate. Everybody may not necessarily be plasma, I'm not sure. Anyway, that's what that means. Everyone may not be having centrifugal plasma exchange, which is the preferred modality which you'd like to do. While in contrast, only 3 patients underwent cadaveric liver transplantation across Tamil Nadu for this indication. A few more patients would have had live donor liver transplantation. I am guessing that data is not there in public domain. I am guessing it is 5. It cannot be 1,000. Europe does 28 transplants in 22 countries per year. So this is the scenario where we are all working in. Next slide, please. Now this is a photograph when some of our team members got together for a lunch time, just to say the composition of a team, which I believe is what our state should aim for in each of the centers offering these. So first is, it is not a single person effort, it's a team. The team comprises of 2 sets of people. One is a clinical team and 2 is an apheresis team. Also, the team comprises of doctors, specialist nurses, and technicians. Now, the clinical team can be, that now depends on each center. For us, it's hepatology at CMC Vellore. It can be physician, it can be a pediatrician, it can be a toxicologist, it can be a gastroenterologist, it will vary. The apheresis team, because it's a centrifugal PLEX machine, is a preferred modality, should be transfusion medicine. Now, over time, I hope that in Tamil Nadu, this model happens in all centers. And I'm giving an example of, we should clarify the role. The transfusion medicine doctor is not the person to interact with the patient, obtain consent, etc. That is not that person's job. The clinician has no idea about the machine. I do not know anything about the machine. In fact, I hope I can identify the machine. No, I do not know. That's not my role. So there are clearly separate roles. I hope that this happens across Tamil Nadu. Next slide. Now this is my last slide. So what are the unique features of the Tamil Nadu government protocol to treat rodenticide hepatotoxicity? 1, this is the world's largest system to triage these patients for urgent plasma exchange. This is the biggest. 2, as I mentioned, in contrary to the current Western guidelines, we say treat liver damage early with PLEX. Why do you want to wait till the person is more and more sick? 3, PLEX is the first choice treatment. Second option, liver transplant, if accessible. It's a much more demanding question in India, but even in the West is the same, but it's ulta there right now. And lastly, the indications and contraindications for PLEX to treat acute liver damage from poison ingestion is the world's first. There is, as of now, no such document. So we are in some sort of groundbreaking area, and I would encourage all of us. There is lots of research to be done. There are many data with all of you, your own centers. It's only a matter of putting our minds together and taking that forward. Thank you.
Thank you, sir, for that excellent presentation.